Hello guys, welcome to our channel. Today we are going to discuss the expected topics too. And in this we are going to cover the almost 30 plus topics. So let's start. Before that, those who haven't subscribed yet, please do subscribe and share with your friends. So let's dive into the topics. So the first thing that is the most commonly and easily answered question, epithelium. So we have to focus on the only three types of the epithelium. The first one is a simple squamous epithelium. You have to know what are the examples of the simple squamous epithelium, especially your blood vessels like endothelium, fenestrated endothelium of the your kidney glomerulus, and also the air sacs. In the alveoli also, there is only simple squamous epithelium. Next, coming to the simple columnar epithelium. So the columnar epithelium has a specific structures that are your cilia for the locomotion and the mucous membranes absorption. So what are those structures? Especially the smooth muscles, the digestive tract, and also bladder. All these uterine structure, bronchi, all this will be contained in the simple columnar epithelium. Next one is your pseudo-stratified columnar epithelium. Almost all the respiratory system will be having the pseudo-stratified columnar epithelium with the cilia. But the inside the alveolus, that is your simple squamous epithelium. And the last one is your transitional epithelium. This will be lining the urethra, ureters, and the bladder. And this is also asked the question, stratified squamous epithelium that is present in the esophagus, mouth, and the vagina. So epithelium type and their location is very, very important. And last year, there is a question on the elastic cartilage. So we can also expect the types of cartilage and their what are the examples. So in the last examination, they directly gave this picture only, histology picture, and they asked what is this type of the cartilage. So in that the examples are especially your eustachian tube, external ear, epiglottitis, and the corniculate and the cuneiform. So whichever the cartilage which is in your inside your larynx structures now, that is all belongs to the elastic cartilage. And the hyaline cartilage will be your trachea, bronchi, thyroid cartilage, and the sulfide cartilage. So only the most important one, at least you have to remember. And the fibrous cartilage will be intervertebral disc and also the apex of the arytenoid muscles. So these are the cartilages and their types of examples. So next one is your neural tube defects. So neural tube defects is subdivided into the two types, guys. One is your anterior type and other one is the posterior type. Okay. So we have the anterior neuropore and the posterior neuropore. So anterior neuropore will be closing by 25th day of intrauterine life. Okay, intrauterine life. And posterior will close by 28th day of intrauterine life. So if they mentioned in the weeks, this is the 3 weeks and this is at 4th week of the intrauterine life. So in the first anterior neuropore, if it is not closed at the 25th of the day, so what is the chance? So there is a high risk of development of this anomaly. What is this anomaly, guys? This is anencephaly. So most commonly, if the anterior neuropore is not closed, so the cause will be anencephaly is seen in the patient. And how this is going to be seen in the ultrasound? In the ultrasound machine, it is going to be show the sign of frog face sign. Okay, this is seen in the patients of the anterior neuropore anencephaly patients. And posterior, in the posterior neuropore, if it is not closed by the 4th week, most commonly the children will be presenting with this kind of defect. So this defect is known as, and this is most common, and overall all the embryonic defects of the neural tube defects, this is the most common, spina bifida. Okay, these are the things that can be happened in this patient. And in the posterior neuropore or anything, the most common and severe one, that is your myelomeningocele. And what are the cause for this neural tube defects? Usually, this neural tube defects will be caused due to multifactorial. Okay, it is not belongs to any Mendelian or any other traits. It is multifactorial inheritance. And those who are taking the anti-epileptics, so mothers, those who are having the epilepsy, they are taking some kind of drugs that will also cause. And we also established that folate deficiency can also cause to the neural tube defects. So let's say the patient is in the pregnancy, she is having the diabetes mellitus. Diabetes mellitus mother. So in this, the infant is having the risk of development. So the most common will be anencephaly only. Okay, anencephaly with the uncontrolled overt diabetes. But if the patient is having the most specific, if we say, that is your craniobrachyscasis. Okay, this is the most specific one. And this is seen in the overt diabetes. Okay, overt diabetes mellitus. And how can we tell the risk that the patient is having. So the more HbA1c is high, and at the same time, neural tube defects will be high chance. So this is directly proportional to the risk of neural tube defects in the diabetes mellitus mother. And let's say, what is the treatment that we can prevent this neural tube defects? We have to start the patient on the folate. Okay, so the folate treatment should be given for each and every pregnancy patient in the first trimester. What is the normal dosage? You have to give the 400 micrograms per day. Let's say that the patient is having the history of the neural tube defects. In this patient, we have to start the 4 mg. Okay, don't confuse. This is 4 mg, 4 mg per day. And let's say that the patient is having the diabetes mellitus, patient is having the any other conditions, then also any other comorbidities, we have to start the patient on the 400 micrograms per day. And sickle cell anemia. These sickle cell anemia patients, we have to give the 5 mg per day. And those who are taking the anti-epileptics, and these anti-epileptics patients also, we have to give the 4 mg per day. Okay, epilepsy drugs taking patients. Okay, this is what the protocol for the folate treatment. Next one is your inborn errors of the metabolism. Let's discuss what are the types of inborn errors that is most important for our exam. So the first one is your galactosemia. So we all know that galactosemia is a classic conditions. Hepatomegaly, patient is having this galactose intolerance. What is the gene that is involved? That is your GALPUT1 gene. Okay, GALPUT1 gene is involved. In this patients, what we are going to see? Oil drop cataract. And these oil drop cataract is reversible. If the patient is treated, then this is reversible. And in this patient, what is the one thing that you have to remember? Absolutely, this patient should not be given the breastfeeding. Okay, absolute contraindication for the breastfeeding. Next one is the lactose intolerance. Lactose intolerance can be two types, primary and also the secondary. So secondary is seen in the acquired conditions. So primary is most commonly by birth only. Why? This patient does not have the lactose. So total loss of the lactose will lead to the patient intolerant to the lactose carbohydrate. So that's why, so these patients also absolutely contraindicated for the breastfeeding in the babies. And next one is the G6PD. So G6PD is the most common type of the hemolytic anemia in the India. Okay, intravascular, these patients will be having the G6PD deficiency. And what is the G6PD inheritance? It is X-linked recessive. Okay, mostly the mothers is going to transmit this to the babies. And next, what is on the peripheral blood smear? What is going to see? Hens bodies. Okay, so the hens bodies are the bite cells that is seen on the plasma blood smear. And the best thing that the G6PD patient, they never have the malaria. Okay, they never have malaria. But if you give the anti-malaria drugs, there is a high chance of the hemolytic anemia chances. So they don't have the malaria, but in case if you by mistake if you give the malaria drugs, there is a high chance of the hemolysis in this patient. Next one is the maple syrup urine disease. In this, what is that dysfunction? The enzyme will be branched chain keto hydroxylase. This enzyme is deficient in this patient. What are these branched chains? We already discussed, that is your valine, leucine, and isoleucine, right? These are the amino acids branched chain is involved in the maple syrup urine disease. Next, coming to the most common type of the inborn error metabolism worldwide. So worldwide, if we say this is the most common, that is your phenylketonuria. So in the phenylketonuria, what is the enzyme that is deficient, guys? That is your phenylalanine hydroxylase. Okay, this is the enzyme that is involved in this patients. But in India, the most common one is the MECAD, okay, medium chain fatty acid deficiency. So this is the most common in India. Next one is your alkaptonuria. So alkaptonuria is the first disease that is discovered in the inborn errors of metabolism by the Garrod. So the scientist Garrod, he discovered this one. And what is the enzyme that is deficient? Homogentisate acid. So homogentisate oxidase, this is going to be the deficient in this patient. Usually this patient will be having the black urine. That's why it is also known as the black urine disease. And onchronosis. So this black pigment is seen in the patients of cornea, pinnae, and other regions also. There is a pigmentation that is seen in the alkaptonuria patients. Next one is your tyrosinemia. So in the tyrosinemia patients, there are three types, right? So type 1 is your oculocutaneous. What is the enzyme that is involved? Fumarate acidase. In the tyrosinemia type 2, this patient will be having the classical condition, that is name itself tells, tyrosine transaminase. And the type 3 that will be involving the neonatal type, this is your enzyme PHPP dioxygenase. All right. Next one is the albinism. In the albinism, what is the enzyme that is involved, guys? That is the tyrosinase enzyme deficiency. All right. Next one is your heart knob disease. In the heart knob disease, this is the kidney transporter defect. What happens? So there is a decreased chance of the tryptophan that is excreted from the babe, excreted from the patient. So this will be leading to the high pellagra symptoms. Okay, due to niacin deficiency. So these patients will be having the pellagra-like symptoms. What is the pellagra symptoms? What we discussed, like your D's. So diarrhea, dementia, dermatitis. If you're not treated, there will be a cause of death also. That is a heart knob disease. And also you have the other disease, that is your cystinuria. So cystinuria is also kidney defect only. In this, there is a high chance cola. What is cola, guys? Your cysteine, lysine, arginine, and ornithine. All this will be lost in the urine. So this is known as a, remember the mnemonic as a cola. These 4 amino acids will be lost. All right. So, and also you have the some other disease. For example, the Refsum disease. Refsum disease is due to deficiency of the phenolic acid. Okay, phenolic acid. And also you have the Zellweger disease. This Zellweger disease is due to deficiency of the peroxidase. Okay, these are the things that you have to remember. And Leishman disease, that is due to HGPRT disease. All right. Next, moving on to the burns and their classifications. So if you see this picture, the rule of 9, what is this rule of 9, guys? That is your Wallis rule of 9. So this is estimate the total body surface area that is involved in the patient's condition. So most significantly, what is the single most significant risk factor for the patients having the risk of pulmonary compromise? So the most significant is the burnt or signed air. Okay. So in the nasally, the patient having this burnt or the signed a nasal hair, which will be leading to the pulmonary compromisation. So this will lead to the pulmonary compromisation. Eventually, patient will be landing into the acute respiratory distress syndrome. And if it is progress, the patient will be having the secondary infections. So bronchopneumonia can be possible in these situations. Okay, this is the one thing. That is why patient will be having the mortality with the respiratory compromise only. But if you see, if you divide the cause of death in this patient, so immediately, if the patient is brought to the hospital within hours, if the patient is died, that is most likely due to asphyxia only. Okay, but if the patient is died within the 24 hours, then that is likely to be the hypovolemia. So due to loss of the volume in the body. And if the patient is died more than 48 hours, more than 48 hours, this is likely to be the septic shock. And what is the organism that is involved in this septic shock? That is the Pseudomonas. Okay, Pseudomonas. And most commonly, the question 1 is asking how to treat this patient. So treatment is always fluid resuscitation. Okay, you have to maintain the fluid. For this, what we can use, that the formula we can use is the Parkland formula. Okay, in the Parkland formula, how we are going to apply in the in the previously, what we are going to use, 4 into body weight, patient body weight into total body surface area is involved. So this is the old formula. Nowadays, we are cut short into 2 into body weight into total body surface area. We are calculating. All right. So what is the fluid of the choice? So for this patient, basically we are going to give the RL only. So this is the most preferred fluid of the choice. And how to going to give whatever the value is came, you have to divide into 2 types. So first 8 hours, you have to give the half of the fluid. And the next, whatever the left for half, you have to give for the 16 hours. Okay. So like this, you have to give for this patient. right? This is what the Burns classification. Here you can see this is total, the front area is 9 and the back area is 9. That means 4.5 and the 4.5 for this patient. And the anus regions are 1. And truncal is also going to like that only 4.5, 4.5 and 4.5, 4.5 for these patients. And next upper limbs also 4.5, 4.5 and lower limbs also 4.5, 4.5. So like that you will be getting the 100% of the total body surface area. Next one, the common one, trauma patients. Whenever you see trauma patients, you are going to check the GCS. This can be asked in the surgery question itself. So if you see the GCS patient, if the eye opening does not have the eye opening, that will be 1. If the patient is opening for the pain, that is 2. And patient is only commanding for the verbals, like patient is giving what is his name, patient is giving the anything like asking about his mother, that will be considered to be the 3. And patient is opening the eye sounds, anything spontaneously, that is 4. Next, coming to the verbal, patient is oriented, that is 5. Patient is confused but able to answer. Then same again, the patient is telling about his name and he is responding well, that will be 4. And patient is using the inappropriate responses. For example, patient is cursing us or patient is like using the bad words, shouting loudly, that will be the 3. And incomprehensible sounds. Patient is only making the sounds for pain. For example, he was like desperately, he was in the pain, he was just mourning for the pains. That is also for the 2 score. And no verbal response, 1. And coming to the motor is very important, always confusing also. So if you see no motor response is 1. And patient is having the extensor decerebrate posture. This is 2. Patient is having the abnormal flexion, that is 3. And patient withdraws the pain, 4. And purposeful movements with the pain, that is 5. And obeys to the commands is 6. So this is like EVM. So EVM 4, 5, 6 is comprises to 15 is normal. And if you see patient is between the 3 to 8, that is severe brain injury. And if it is 9 to 12, moderate brain injury. And if it's 13 to 15, minor brain injury. So at least this calculation can be asked in the examination. So next one is urethral trauma. Urethral trauma is divided into the 2 types, guys. One is the anterior urethral and also other one is the posterior urethral. So why this happening? So if the patient is having the pelvic fracture, okay, patient is having the pelvic fracture, likely to be these bulbar will be going to rupture. And if the patient is having the membranous, this membranous one, if the patient is having, if the patient is having the penile one, that is due to straddle injury. Okay, straddle injury, patient will be having the penile one. But in the membranous one, this is the membranous type in the seen in the pelvic fracture. So we have to know where this urine is going to stagnate. So that is the question most likely asked. So in the membranous one, mostly this is going to ride upside. Okay, it is going to ride upside in the prostate and also superficial peroneal pouch. Only these two are going to occur. And in the straddle injury, it is going to reach the scrotum. And if the Buck's fascia, this is the Buck's fascia. If the Buck's fascia is damaged, it is also going into the penile region and deep peroneal pouch and anterior abdominal wall. Okay, anterior abdominal wall. So this is where the most of the urethral trauma types and their urine stagnation. Next one is the epidemiological studies. Epidemiological studies are divided into 3 types. One is the observational and other one is the experimental. This experimental is subdivided into the randomized control trials, non-randomized control trials, and also evidence-based medicine. Okay, and observational is subdivided into the descriptive type and analytical type. In the descriptive type, we have only 2, that is a case study. For example, COVID-19 first case is published in the descriptive only, like place, time, and these regions. Based on that, this is formed. And case series also we can say. Next, analytical having the cohort, case control, and patient having the like cross-sectional and ecological. These are the analytical. Let's see what are the types of what is mean by the cohort, cross-sectional, case control. So first one is the cohort. Cohort is always you see, you take the two groups, and two groups future, you are going to see whether they are going to develop the disease or the no disease. Okay, here also disease and no disease. Okay, two different groups. You are going to look for their future. This patient is having some exposure. This patient is developing this disease. This patient does not have the exposure, still he developed disease. So you are going to look for the future. Okay, this is the prospective type of the study. And for this, what you are going to check? Relative risk you are going to check. Okay, and this is specifically focusing on the incidence. So new cases, what we are studying is the cohort, right? Next one is the case control. Case control, you are going to take this again same groups. So no disease. So you are going to look back their future. Sorry, past. Okay, past. In the past, you are going to see risk factor is present and risk factor does not have. So here also risk factor present, risk factor does not have. So in the back, the past of the patient is seen, that is a case control. For this, you are going to take the odds ratio. Next, third one is the cross section. Cross section is done in the present. Okay, this is done in the present only. For this patient, what we are going to see, the cross sectional present population only, and we are going to look for the prevalence. Okay, prevalence is always going to be the new cases plus the old cases, right? This is what the cross section. And ecological also present only, but they will be having the population as a unit. Okay, population will work as a unit. So this is your experimental ecological epidemiological studies. Next one is the vaccination. So this is our national immunization schedule. So at birth, what we are going to give? BCG, OPV, oral dose, and also hepatitis birth dose, right? And 6 weeks, we are going to give the OPV next dose, pentavalent rotavirus, and also pneumococcal conjugate vaccine. 10 weeks, we are going to give the second dose of the OPV, pentavalent second dose, and also rotavirus vaccine oral dose you are going to give. So 10 week at the 10th week also still is going to complete it. And but here we are going to add the PCV2 second dose. In the 10 weeks, we are not going to give the PCV second dose. And 9 to 12 months, the first vaccine that is given, measles and rubella, along with that JE1. JE1 is given in the only endemic regions like northeastern regions we are going to give. And PCV booster is given. PCV2 have only 2 types of the vaccines and another one is the booster. And 16 to 24 months, again, measles second dose, diphtheria pertussis first booster, and OPV booster we are going to give. So 5 to 6 years, DPT2 booster you are going to give. At least if you remember this can be asked in the examination. Next one is the pregnancy patients at their vaccination. So for the pregnancy patient, you are going to give the TD. In our PHCs, we are going to give the TD. So first, as early as possible in the first trimester only, you are going to give intramuscular to pregnancy women. And second dose will be given after 4 weeks of a part. So first trimester she came, and next month you are going to give the tetanus dose for the patient. But if the patient is having the last pregnancy less than 3 years, you are going to give the booster dose. If it is less than 3 years, the booster is fine. If it is more than 3 years, again you have to repeat the 2 doses. Right? This is the protocol that we follow in the PHCs. Next one is the waste management and how to go into discard. In the yellow bin, you are going to throw all the human waste. What are those? Like placenta and anatomical wastes, like patient is having the any kind of like lipoma excision or biopsy products, all these are going to discarded in the yellow bin. And next one is cotton, whatever the cotton, gauze piece, bandage, and drugs and expired drugs, all this will be discarded in the yellow. Microbiological waste, your petri dishes and your all the cultures will be also discarded in the yellow bin. And infected urine, feces, vomits, this is also discarded in the yellow bin. And bleeding, discarded bedding, lining cloth, empty blood bag, this is also already discarded in the yellow bin. Okay, remember this table. Next, coming to the red one. What are we are going to use? Only the plastic one. For example, gloves, IV drip set, IV cannulas, Euro bags, syringes, suction catheters, police catheters, all this will be, the plastic one will be going into the red one. Next, coming to the blue one, mostly the glass items. Very, very classic, like your metallic body implants, like your discarded broken glasses, all this will be sent into the blue one. Only sharp items, These one will be going into the white one. Okay, this management is also important for us. Next, hypersensitivity reactions. When I say hypersensitivity reactions, the patient will be having the 4 different type of the hypersensitivity reactions. So in that, type 1 will be mediated by the IgE. This is the allergic type of the reaction. What are the examples? Example, anaphylaxis. Patient is having the drug allergy, atopy, fever, and all these food allergies will be considered into the hypersensitivity type 1 reaction. In the type 2, it could be IgG or the IgM. Only the type 2 will be having the receptor dysfunction, antibody mediated. Hemolytic anemia disease, patient is having the transfusion reaction. This will be considered into the type 2. In the type 2 also, you have the other one. One is your Graves disease and Myasthenia gravis. Okay, these two also type 2 hypersensitivity reaction. In the type 3 reaction, both at a time will be happening. Post-streptococcal glomerular nephritis. She have the IgM because of the past infection. IgG also present. Rheumatoid arthritis, systemic lupus, and also patient will be having the arthus reaction. And coming to the 2 types of the lepra reaction. Lepra reaction will be followed the rule of 5. So after seeing that type 4, we will be seeing what is this rule of 5. So in the type 4 reaction mediated by the late onset, that is the T cells, contact dermatitis, type 1 diabetes mellitus, multiple sclerosis, and also patient will be taking the Montauk's test. Okay, these all belongs to the type 4 of the hypersensitivity reaction. So what is the rule of 5? So rule of 5 means patient is having the lepra reaction type 1. So if you want to make the score 5, how much you have to add? 4. So type 1 is belong to type 4 lepra reaction. Next type 2 lepra reaction, how much you have to add? 3. So 3 plus 2, 5. So type 2 will belongs to the type 3 lepra reaction. This is what rule of 5. Next topic is the rabies prophylaxis. So when I say rabies prophylaxis, most commonly that is used in the post-exposure prophylaxis. So how that is categorized? So it is categorized into the 3 types. Category 1 and category 2, category 3. How this is should be classified. So in the category 1 patients, how we are going to see whether the patient is only have the normal skin and no kind of abrasions or any scratches. Patient is just had the licking or the nibbling from the pet animal. So what you have to do, you just have to do the wound care and also you have to wash for the 15 minutes. So this is must. And category 2, what they are happening? So they are also having the licking or the nibbling only, but at the same time, they might be having the scratches or skin abrasions. In these situations, you have to take the wash again for the 15 minutes. Then you have to take the wound care, add the TT injection, plus along with that, you are going to ask the anti-rabies vaccine. Next, category 3 patients, if the patient is having the severe bleeding or patient is having the injuries in the neck region, then you have to intervene immediately, give the patient same wash and also wound care, start the patient on the antibiotics first line and then give the ARV. Along with that, you also have to give the rabies immunoglobulin and plus TT injection. So this is what the category that we are going to follow WHO worldwide. But how to give this therapy? So we have the 2 types. One is the SN regimen, other one is the Thai regimen. What we are using here is the Thai regimen. So SN regimen having the words of the 5. So 5 letters have the 5 different days. So day 0, day 3, day 7, along with the day 14 and day 28. This is how we are going to give the post-exposure prophylaxis. And in the patients of the Thai regimen, what we follow 0, 3, 7 and 28. This is what we follow in the Thai. This is the post-exposure, guys. Don't confuse. This is the post-exposure. Next, we also have the those who need the pre-exposure like forest people or any vulnerable jobs. Then they have to take the pre-exposure prophylaxis. For this pre-exposure, the name itself again 3 letters 0, 7, 21. And re-exposure, if the patient is having the less than 1 year and vaccination, only booster is fine. But if they are less than 3 months, then you have to do the only re-exposure, that is 2 letters 0 and 3rd day. Okay, pre-exposure, re-exposure and the post-exposure prophylaxis for the rabies and their categories. Next, coming to the tetanus. So how tetanus is classified? So in the tetanus also we have the different categories. Category A, category B, category C and D. What is these four categories? So category A people, they have the TT injection less than 5 years. Okay. And in the patients, those who are category B, they have the vaccination less than 10 years. And category C, more than 10 years with the history of TT injection. And they don't have no history, no memory. That's why they landed into the category D. And how to do the wound care in this patient? If the patient is having the category A, they have the wound like clean wound or unclean wound, you just have to give the wound care only. No need to go for the TT injection because less than 5 years only. And in the category B, you can give the still TT injection of the single dose. Okay, single dose can be given for this patient. Category C patients, what we have to do, you not only giving the TT injection, along with that, you have to give the human tetanus immunoglobulin. This is also given as a single dose. All right. And for the patient's category D, you don't know. For this patient, you have to give the category TT injection, human tetanus immunoglobulin. That has to be given the complete course. Not only the single dose, they have to get the complete course of those injections. So this is what the tetanus prophylaxis. All right. So this table can also be asked in the examination. Next, pharyngeal derivatives. In the pharyngeal derivatives, we have to remember the nerves and the arteries where they are formed. We have the 6 arches. So arch 1 will going to give the maxillary nerve. Okay. Maxillary nerve. Along with that, we will be also having the artery derivative from here. That is mandibular artery. From the arch to pharyngeal arch to stapedial artery and facial nerve. And in the third arch, we are going to have the carotid artery and glossopharyngeal nerve. And fourth arch, in the fourth arch, patient will be having the arch of aorta, development of the arch of aorta, and also superior laryngeal nerve. Okay, superior laryngeal nerve. And in the sixth arch, this is going to give the ductus arteriosus in the birth, in the fetus. After this ductus arteriosus closure, this is also going to give the right and left pulmonary arteries. Okay, right and left pulmonary arteries. And sixth one, what is the nerve? That is recurrent laryngeal nerve. Left side of the recurrent laryngeal nerve is broad and derivative of the sixth arch. Fifth arch is not that much important. Next, coming to the another question commonly asked, cleft lip patient and cleft palate. So cleft palate, you all know cleft lip is due to failure of medial nasal process that is not completely medial nasal and the maxillary nasal process is not completely formed. That is why the cleft lip is formed. And coming to the cleft palate, what is the reason? Due to not fusion of the palatine fossas. Okay, this is why patient is having the cleft lip and the cleft palate defects. Next one, cartilages and the muscles of the larynx. So we have the two types, unpaired and paired. Okay. Unpaired, those are thyroid, circoid, and epiglottis. These are unpaired. And next one is your paired, arytenoid, cuneiform, and corniculate. These are the paired type of the cartilages of the larynx. And the nerve supply for this, all cartilages is supplied by the recurrent laryngeal nerve. Okay, first thing. But there is an exception, that is your safety muscle. What is this safety muscle? That is not supplied by the recurrent laryngeal nerve. Okay, it is your circoid muscle. Okay, posterior sigmoid muscle. It is not supplied by the recurrent laryngeal nerve. It is supplied by the external laryngeal nerve. Okay. This point is also important for the exam. Right? This cartilages of the larynx and the nerve supply is important. Next, coming to the food adulteration. In this, you have the specific diseases causing the patient's vulnerability of the misuse of the food adulteration. What are those? First one is your neurolathyrism. So this neurolathyrism, patients, those will be having the in the villages previously, the paralysis, sudden onset of the paralysis due to diet. What kind of, they have these food yellow pulse, or famously known as your kesari dal. These contains the specifically the Lathyrus sativum. Okay, the Lathyrus sativum that is present. This toxin is going to cause the neurolathyrism in the patient, because this neurolathyrism have the specific component, that is your beta oxyl amino alanine. Okay, and this will lead to dysfunction of the peripheral nervous system. What we can do, you have to start the patient on the vitamin C. Simply the vitamin C, the 500 mg dosage can be given for this patient, and ban that crop, educate the patient. And also you have to do, when the patient is taking this kesari dal, like patient is having the cultivation of the kesari dal, you have to make sure that toxin removal should be done from the these yellow pulse. Okay. Next one is the epidemic dropsy. Epidemic dropsy. And in the name itself, drop, this will be leading to the fluid accumulation in the body. Your congestive heart failure or the anasarca. Okay, this is causing in the patient epidemic dropsy. What is the chemical that is involved? Sanguine. Okay, sanguine. And from the mustard or from the argemone seeds. Okay, argemone seeds is going to cause the congestive heart failure and anasarca with the epidemic dropsy. And third one is your endemic ascites. Okay, endemic ascites. This is due to pyrrolozinamide. Pyrrolozidine. And this is usually patient those who are taking the millets, misuse of the millets adulteration, or the junjunia seeds. Okay, junjunia seeds or cotterella seeds. So this is going to cause the endemic ascites in the patient. So your fourth one is your aflatoxinosis. Okay, aflatoxinosis. So the toxin itself, aflatoxin, is going to involve the patient liver. So this is highly hepatotoxic. From where this is going to come? The fungus that is involved for this is Aspergillus flavus. Okay, one thing. Next one is the ergotism. Ergotism is basically the patient is having the gangrene developing. So the ischemia in the vascular digitals, the patient is risked the ergotism. And seen with the ergot alkaloids, or patient those who are taking the these kind of exposure with the claviceps fusiformis. Okay, claviceps fusiformis. Okay, this is going to cause the gangrene. So this is the food adulteration of the patients. Next one is the disaster. So disaster will be coming under which ministry, guys? Home Ministry. Okay, Home Ministry of India is going to find the disaster management. How this disaster cycle will be formed? So first, there is a history of the disaster, droughts, floods, or the cyclone, anything that is an impact is going to cause. Impact is going to cause the response, and this will be leading to the rehabilitation. Okay, this is the post-exposure, right? This is a post-exposure to the disaster. But before that, you have to make sure that once the rehabilitation is done from the previous history, you have to do the mitigation. Okay, mitigation. From that, preparedness should be started for the next disaster. Right, this is the cycle for the pre-exposure. Okay. First, if there is a history impact, this will cause the response and rehabilitation for the patients. And next part, you have to mitigate and then you have to start the preparation for the next disaster. Right. And for this disaster also, there is a question that is asked. Most commonly, they will be effect of which disease? That is gastroenteritis. Okay. Gastroenteritis is commonly seen in the post-disaster. Along with that, next one is the pneumonia. Okay, respiratory system involvement. But what is the role of the vaccine? No role of the vaccine. Okay, no role of any vaccine. But in the children, even though they are less than 9 months also, you can give the measles for this patient along with the vitamin A. Coming to the chlorine, for this patient, the chlorination should be more than 0.7 ppm should be given. And what about the any other injections? TT. So TT should be given for all the individuals of the patients. So this is what the disaster overview. Next, coming to the tumor markers. So in the tumor markers, not only tumor markers, we have included the oncogenes, tumor suppressor genes, and carcinogens. So let's see what are those examples. For your RAS-K colon cancer and the pancreatic cancer, RAS-H oncogene will be causing the renal carcinoma and pituitary carcinoma. RAS-N for the melanoma. ABL gene for the your CML and BRAF gene for the hairy cell leukemia. MIC-C, Burkitt's lymphoma, MIC-N, neuroblastoma. MIC-C is for the lung carcinoma. And cyclin D, mantle zone, and PDGF, astrocytoma. FGF is the fibrosarcoma. HGF for the hepatic cellular carcinoma. PDGFR for the glioma, EGFR for the adenocarcinoma of the lungs, and EGFR2 for the breast cancer. Red gene for the MEN syndromes and KIT gene for the GIST, like your gastrointestinal, and AML, melanoma, and seminoma. ALK for the adenocarcinoma of the lungs, and CDK4 for the glioblastoma. Next, coming to the carcinogens that is causing, already we discussed aflatoxins, hepatocellular carcinoma, aromatic amines like benzidines, naphthalene this is going to cause the bladder cancer. And ionizing radiation, leukemia, papillary thyroid cancer. So the most radio resistant is your papillothyroid cancer. Nickel, chromium, beryllium, this is going to cause the lung cancer. Arsenic, vinyl chloride, hepatic angiocarcinoma. Aflatoxin, hepatic cellular. Hepatic angio is arsenic and the vinyl chloride. Next, tumor markers. So calcitonin is positive for the medullary carcinothyroid. And AFE is positive for the yolk sac tumor, hepatocellular carcinoma. Beta HCG for the germ cell tumors, and patients for the PSA, prostate cancer, catecholamines for the pheochromocytoma, and CEA for the colon cancer, pancreatic cancer. CA72, stomach cancer, CA19, pancreatic cancer, colon cancer. And colon cancer, best is called CEA, and for the CA19, the best one is the pancreatic. CA15 for the breast, CA125 for the ovarian cancer. Next, moving on to the tumor suppressor genes. What are the tumor suppressor genes? P53, 17P, RB gene for the 13Q, and NF1, NF2, 17Q and the 22Q respectively. This is for the neuroblastoma. And the BRCA1 that is going to for the breast cancer, BRCA2 for the breast cancer, 13Q chromosome. WT1 for your 11P, Wilms tumor, WT2 also Wilms tumor. VHL gene for the renal cell carcinoma on the 3P gene, and the RB gene that is also commonly asked retinoblastoma. So next discuss going to be the emergency contraception. Emergency contraception, most commonly used drug is the I-pill. What is this is going to contain? Levonorgestrel. Okay, levonorgestrel is the ingredient that is present. For this patient, the dosage is 1.5 mg, single dose is given. Or you can divide into the 0.7, 12 hours you have to give. And this should be given the less than 24 hours as immediate as possible. This is most commonly widely used. And second one is your UZP method. So what is this UZP method? In this UZP method, we are going to give the OCP, oral contraceptive pills. And oral contraceptive pills is going to contain the ethinyl, right? Ethinyl estradiol. And along with that, norgestrel combination. How this drug is given? For this patient, we are going to give the first 2 tablets, start dose, and next after 12 hours, next 2 tablets is given. Okay, this is what the UZP method. Next, the most effective. So when I say most effective, even though patient is not taken less than 24 hours, but at least less than 5 days, patient should be taking the copper IUD. Okay, copper IUD. This is most effective. Other than this, we also have the another most effective emergency contraception, that is your ulipristal acetate. Ulipristal acetate. What is the dosage of this one? 30 mg single dose. Okay, this can be also most effective. And another one is the mifepristone. This is the 50 mg, again given in the single dose. Okay, these are the emergency contraception, very important for the examination. Next, healthcare infrastructure. In the healthcare infrastructure, we have to see how many people or how many subcenters PHCs is allocated as per the population by the government of India. So when I say ASHA workers, so ASHA workers in the rural region, they are allotted 1 person per 1,000 population. Okay. And what about the sub-centers? In these sub-centers, basically there will be only 2 persons, MPW, multi-purpose worker male plus female. And how that is subdivided into the hilly areas. In the hilly areas, it is 3,000 people. And in the plain areas, 5,000 population. This is how sub-center is divided. And PHCs. In the PHCs, we all know there will be a staff, multi-purpose workers. Along with that, there will be a medical officers also. And these medical officers are allocated duties. As per hilly area, the population is 20,000. And in the plain regions, this is divided into the 30,000 population. Right. Next one is the CHCs. So in the CHCs, they will be having the specialist also, like pediatrician, maternity doctor, all this will be presented here. And for the hill regions, it is around 80,000. For the plain, it is more than 1 lakh, approximately 1,20,000 population. Next, coming to the district hospital. For the district hospital, this is not only having a specialist, along with that, labs is presented, blood bank is presented, even OT is also presented in this patient, and pharmacy is also having here. So for this patient, the population will be more than 1,50,000 only. Okay, even in the hilly region also, 1,50,000. Next, urban one. So this is different from the urban. Urban ASHA is going to be having the 1 person for the 2,500 population, and ANM people, these are also like nurse only, and they are for 1 per 10,000 population. And urban PHC is going to have the 50,000 population is going to consist. An urban community health center will be having the 2,50,000 population. Okay, this healthcare infrastructure of India is very important. So let's see. So first, the vaginal infections, bacterial vaginosis is caused by the Gardnerella vaginalis bacteria. So this is a bacterial infection caused by the Gardnerella. Next one is the trichomoniasis. This is the type of STD, guys. What is the causative agent? Trichomonas vaginalis. And the Candida is caused by the Candidiasis fungus. And what is that specific features for this? Gardnerella is going to have the thin grayish white color, fishy odor smell. And next, there is no itching or sometimes mild itching will be presented. So strong fishy odor will be presented after the sexual intercourse in the patient. Bacterial vaginosis. Here you can see this is the thin grayish white color of the discharge is present on the patient. And how we have to treat? The patient has to be given the metronidazole for the 3 days. And you need to treat the patient of the partner? Mostly no, because this is only vaginal infection due to sexual intercourse, but due to the vaginal flora, but not from the partner. So this cannot be sexually transmitted diseases. Next, coming to the trichomoniasis. This will be having this classic feature, strawberry cervix. How this like this hemorrhagic or on the scene on the cervix, this is known as the strawberry cervix. And what is the discharge color? Yellow-green color, foul-smelling, fishy discharge will be present in this patient. And the itching is also intensified after the sexual intercourse. And yes, you have to treat the patient partner also, along with the metronidazole treatment only. Coming to the candidiasis. In the candidiasis, the classic feature, cottage cheese type discharge is presented and severe itching. Because fungal infections always having the trigger of the itching. So itching is intensified, cottage cheese type, and smell is not present. All this will be features of your candida. And treatment will be fluconazole. Don't need to treat the partner. And another points that you have to remember for the patients of this one. So for the candidiasis patient, there is this criteria, Nugent criteria should be followed. And this is also asked previously question for you. Next, coming to the STDs. In the STDs, we have the four types: the chancroid, syphilis, lymphogranuloma, and donovenosis. The positive agent of the chancroid is the Haemophilus ducrei, and how this is going to present it as painful. So chancroid D and ducrei D, and very painful for this patient. Okay, dard bahut hoda, DDP. Okay, painful. You have to remember, and this is how the lesion will be. This is the base of the bleed. Even on simple touch also patient will be having the painful. And along with that, even the inguinal lymphadenopathy is also painful for this patient. And on the culture, you will be seeing this classic picture, school of fish or the railroad appearance. Drug of the choice is azithromycin. Next one is a syphilis. The causative agent, Treponema pallidum. And in the causative agent for syphilis, painless chancroid and painless lymphadenopathy. And lymphadenopathy will be rubbery. And dark red, dark field microscopy, proximate motility you will be seeing. And benzathine penicillin is the drug of the choice for this patient. Coming to the lymphogranuloma venera. This is due to chlamydia trichomoniasis, but the serotypes are L1 to L3. And what is the features? Painful buboes is present, but painless chancroid will be seen. So ulcer will be painless, but the lymphadenopathy will be painful. And this is what groove sign. So this is the lymphadenopathy. This is what groove sign is present in this patient. The NAT is the nucleic acid amplification test is the best one for the chlamydia. Next, the doxycycline is your drug of the choice. And donovenosis is caused by the Klebsiella granulomatous, painless beefy red color. Here you can see this is a very bleeds on the event simple touch, and no pseudobulbs are seen in this patient, and no lymphadenopathy present in the donovenosis. And donovan bodies is seen in the safety pin appearance on the culture. Next, azithromycin is the drug of the choice. And here you can see STD syndromic case management. So this is also commonly asking question. And another one is also added, that is a brown color. So brown color is given for the anorectal. New update. But remaining all for what? So gray one is for the patients with the urethral or the cervical discharge. And next one, the green color one is for the vaginal discharge, and blue color for the genital ulcers, which is non-herpetic. Okay. And the red color one for the herpetic types. So in this, you will be having the acyclovir. Herpetic type is the red color. Non-herpetic is the blue color. And yellow one for the lower abdominal pain, vaginal discharge. And the black one is for the inguinal buboes. This is given for the males who are having the inguinal buboes. Okay. Gray one, cervical, urethral, scrotal discharge. And vaginal for the green one. Blue for the non-herpetic. Red for the herpetic. Yellow for the lower abdominal pain, and black for the inguinal buboes. Okay. And brown for the anorectal discharge. This STD kit also very important. Next topic, pneumoconiosis. The most common overall pneumoconiosis is the silicosis. So silicosis is due to silica dust exposure. And these patients are highest risk of TB, but no risk of cancer. Okay. Very rarely cancer is seen. On the chest X-ray, you will be seeing the eggshell classifications. Okay. Eggshell calcifications are seen. Next one is the asbestosis. Asbestosis is due to exposure of the shipyard workers, and along with that, these patients are also exposed for the glass works. And what is the main cause? Mostly this will be developing the bronchogenic cancer. Okay, bronchogenic carcinoma is associated with the asbestosis. And what is the most specific? If they ask most specific, then it is your mesothelioma. Okay, next one is your anthracosis. Okay, anthracosis is due to coal dust. Patient those who are exposed to the coal dust, that will be causing the anthracosis, and no risk of TB and no risk of cancer in this patient. Right? Next, bagosis. Okay, bagosis is due to sugarcane and also exposure of the cardboards. Next one is your dysnosis. Dysnosis is due to cotton exposure. Okay, one of the pneumoconiosis question is also commonly asking, guys. Don't forget this one. Next, myasthenia gravis. We all know that myasthenia gravis is type 2 hypersensitivity reaction, autoimmune condition, and very chronic and inflammatory condition of the patient. Mostly seen in the females comparing to the males. And most common antibody that is involved, acetylcholinesterase receptor antibody that is involved. Along with that, the second most common is the anti-musk antibodies. Okay, anti-musk antibodies. What are the symptoms? So firstly, it is going to involve the eyes, palpebral muscle. So ptosis is a common symptoms, early symptom. After that, it is going to involve the patient extraocular muscle, causing the double vision in the patient. Okay. After, it is going to involve the proximal muscles. So usually patient will be complaining will be fatigue, weakness, lower limbs. All this will be common symptoms present in the patient. Next, it is going to involve the facial muscles. Okay. Facial, they will be featured snarling faces, like dog-like faces that is seen, snarling faces or drooping of the face is present. So this is a severe stage already. Okay, severe stage. Next, it will involve the respiratory muscles also. And most sensitive test for this patient is a nerve fiber test. Okay, nerve fiber electromyography, that is the most sensitive. Most specific test, if we say, that is your antibody test. Okay, AC acetylcholine receptor, that test is the most specific one. But most commonly done is the patients usually in the tensilon test can be done or antibody test will be done. For the tensilon test, what is the drug we are going to use? We are going to use the IV hydrophonium. If you give the hydrophonium for this patient, the ptosis is going to improve. Then the confirmation of the myasthenia gravis is established. And even the ice pack test. So ice pack test also usually improves the ptosis of the patient. And whatever the drug of the choice, for the drug of the choice, the pyridostigmine is given for this patient. Okay. And what is the paraneoplastic that is associated? Thymic. Okay. Thymic hyperplasia or the thymoma is involved in this patient. Along with the pyridostigmine, you can do the thymectomy also. Next one, meningitis and CSF analysis. This is also very, very important. Coming to the bacterial, it is going to look as a turbid color. Here you can see it is turbid in color and pressure is raised and WBC, especially neutrophils are highly elevated. Protein is elevated, glucose is decreased. And viral is almost like a normal only. So it is no turbid color, normal or doesn't raise, and mostly lymphocytes is seen because neutrophils are very specific to the bacteria only. And when you see the protein or the glucose, mostly normal only. That's why when we say viral meningitis, it is a aseptic meningitis. Tuberculosis, predominantly the protein is highly elevated because it is a chronic condition, and in the chronic condition, lymphocytes is very elevated, right? And specific feature is cobweb formation, like this. The cobweb formation is seen in this patient. So bacterial, mostly neutrophils is elevated, protein is slightly elevated. In the tuberculosis, protein is highly elevated along with the lymphocytes is elevated. That is what meningitis and the CSF analysis. Next one, coming to the MTP. So we all know that recent 2022 amendment said that up to 24 weeks we can do. So for the 20 weeks, we need the one doctor permission. And for the more than 20 weeks, like up to 24 weeks, we need the two doctors permission. In some extreme cases, if you need the 24 weeks, we have to go for the board permission. In the board, what are the is going to lead this board? Especially gynecologist is the first person. Okay, and sonologist like radiologist is going to present here, and neonatologist. Okay, or pediatrician you can say. These persons is going to lead the board. And next, if the patient, those who are having the contraceptive failure, for this contraceptive failure, it's still less than 20 weeks only or equal to 20 weeks. It's not beyond the 20 weeks, right? And who can perform this? Any RMP who have the 25 above, okay? 25 above assisted, and he will be containing the MBBS or DNB or diploma or MD. They can continue, and they have to get the permission from the government of India. How about consent? Consent is only from the female. And if the female is less than 18 years, or if the female is having the mental retardation conditions, then you have to go for the guardian. And how many years you have to store this? At least 5 years of the record should be maintained. Okay, and you have to give less than 72 hours only. You have to submit for that patient. And coming to the medical abortion, what is the dosage? In the medical abortion, we are going to give the 2 tablets. On the day 1, we are going to give the mifepristone. Okay, mifepristone 200 mg single dose is given. And for the day 3, we are going to give another drug, misoprostol. Okay, this is given 800 micrograms. Okay, this is how the day 1, day 3 is given in the medical abortion. In the surgical abortion, we are going to give the suction evacuation. Next, here you can see this is the types of abortion. So the most common cause, aneuploidy, and if you don't see the answer aneuploidy, choose the trisomy. And if there is no trisomy, also go for the monosomy XO. And if it is monosomy not present, then go for the trisomy 16 or just trisomy you have to choose. This is the most common cause for the abortions. Other than this, torch infections can be, thyroid endocrinopathies can be, all the diabetes mellitus, all this will be having the risk. Next, see the differences here. So threatened abortion due to cervical os is closed, and this is threatened only. Most likely the patient will be having the reversible only, right? So observation is only needed for this patient because fetus is intact, only bleeding is happening, os is closed. This is reversible abortion. Next one, inevitable abortion, cervical os is open and patient should be go for the evacuation because it is irreversible, damage is already done. Next, incomplete abortion, cervical os is open because some of the products is still inside only. And DNC, the dilatation and evacuation should be done for this patient. Complete abortion, the os is closed already because no products is also seen here. So patient observation should be maintained. And septic abortion is likely to be cervical os is open, DNC to prevent the septic shock, start the patient on the fluids and the antibiotics. This is what the septic abortion differences. Next, placenta types. So you have to identify which is the fetal and maternal if it is given. So fetal side, you will be seeing the gray color, so the grayish color, and on the maternal side, you will be seeing the dull red color. So this is just 1/3 only, and this is almost 4/5, right? And it will be containing this umbilical cord on the fetal side and only the cotyledons. This is present on the maternal side. What is this known as? Maternal decidua basalis. On the fetal side, it is known as the vorion frondosum. These 2 points and terms is also important. Next, coming to the types of placenta. So this is the circumvallate placenta and this is the circummarginate placenta. And succinate lobe, extra lobe is present and this is highly associated with the postpartum hemorrhage. Bilobe, equal lobes, there will be presented bilobe or the multilobe. Velamentous, the cord will be having this kind of. So here you can see the cord is intact in the middle of it. So this is like velamentous step. This is also highly risk for the patient or the fetus bradycardia. And battledore is edge. So battledore is like edge. It should be in the middle. But here you can see the marginal insertion of the placenta along with that umbilical cord. Here you can see the difference between the circummarginate and the circumvallate. So circummarginate will be having the smooth surface only, but circumvallate will be having the extra edge. So this will be leading to the placenta. While the placenta is delivering, highly possible of the risk and bleeding will be seen in this patient. Okay, these are the placenta types. Next, cardiovascular changes in the pregnancy. What are the normal changes that is present in the cardiovascular changes? First, the cardiac output is improved, means cardiac output is increased in this patient, and also femoral venous pressure is also increased. Right? Then the patient will be having the decreased peripheral venous resistance. And diastolic blood pressure is decreased. And if the diastolic blood pressure is decreased, mean arterial pressure is also decreased in this patient. And what is does not going to change? JVP is normal. Okay, it does not going to change. And the murmur. So if you see the patient is having the diastolic murmur, it's still normal only. If the patient is having the S2 splitting, then this is also normally seen. Okay. But due to this peripheral venous pressure is increased, this is going to cause the patient at the risk of hemorrhoids, and along with that, patient is also having the risk of varicose veins. Okay, this is the thing that you have to remember. And next, coming to the heart diseases, the most common one is the mitral stenosis. Okay, and most common congenital, that is ASD. Okay, this is the condition that is presented. And heart failure. Heart failure risk is present at wet point. Immediately after the postpartum, there is a high chance the patient can be land into the heart failure, and followed by, if it is not at this, at least in the second stage. Okay, so high risk of heart failure is present in these patients. So this is for our today expected topics too, and tomorrow we'll be ending up with the wrap up remaining subjects with the expected topics 3. So please do watch yesterday video and take notes, and today's also. Please revise this entire topics thoroughly. At least we can expect 30 topics from these 3 videos. Okay. So until then, please keep preparing for your upcoming examination, guys. All the best.